Good morning, good afternoon, good evening, everyone. Thank you all for joining us on this webinar, in which we will discuss the implications of the proposal of South Africa and India for a waiver in order to afford access on an equitable basis to technologies to address the COVID-19 pandemic to all people in all countries at the same time. Just to introduce myself briefly and do some housekeeping before I go into introduction in detail of the webinar. My name is Spring Gombe. I am the program manager of the UN Technology Bank for the least developed countries. I manage a program that's called the Technology Access Partnership, which is looking to afford access to all COVID-19 technologies to all developing countries, with a special focus on diagnostics, medical devices, and personal protective equipment. I would like to take the opportunity to thank the hosts, the Drugs for Neglected Diseases Initiative and Médecins Sans Frontières, for organizing this webinar, which comes at a very painful time for us as Africans and for the African continent. For those who've been working in global health for a while, it is a moment which we reflect on whether this pandemic, like previous pandemics, will take a trajectory in which our continent is again neglected and set aside, or if we will learn from the experience of past pandemics to adopt a truly global approach based on solidarity and an equitable and equitably applied global health policy infrastructure that takes account of the right to health that we all have and the obligations of all our governments to secure that right to health through the formulation and implementation of policies and practices that allow affordable, timely, sufficient, and equitable access to medicines, vaccines, diagnostics, and other essential health technologies. This meeting is prompted by a call from South Africa and India last October. And in that call, South Africa made reference to a looming vaccine apartheid, in which those with the means would have access to medical technologies and those without would be left to die. And we hope that this challenge will not arise again as the COVID-19 pandemic proceeds, but it is one that is particularly pertinent for our continent, where 80% of our health technologies are imported, where a lack of access and policy impediments have before caused fatal consequences. I referenced the HIV pandemic, but we also know that that's true of the H1N1 pandemic. We saw it with Ebola, and we are potentially seeing it with the COVID-19 pandemic. This webinar is focused on an African-led set of recommendations for creating an enabling policy environment to afford all people everywhere access to the health technologies that we need. These center on the proposals of the governments of South Africa and India, but more importantly, they center on a new perspective of management of knowledge and of intellectual property in the public interest in the face of potential unprecedented suffering and death. We're also setting the framework for response to future pandemics. The proposal of South Africa and India has been supported by the AU and the least developed countries group. And so we have with us policymakers who will reflect on what this support means for potential implementation of the TRIPS waiver and other such policy tools to drive a public interest focused health response to the pandemic. The organizers of this webinar themselves offer institutional proofs of the potential to do things in a public interest-driven way. The MSF Access Campaign, which is our first host, was born of the HIV pandemic in 1999, and it traced the lack of access to policy failure and a policy failure that derives from prioritizing a market-driven approach to health and to medicine's innovation and access, with the consequence that those people and conditions that are seen as not profitable are neglected and will continue to be neglected with fatal consequences. The Drugs for Neglected Diseases initiative was created by the Médecins Sans Frontières to together with biomedical research institutes from the public sector of a number of countries that are neglected disease and neglected population endemic, if I can put it like that. And these institutions included the Kenya Medical Research Institute, the India Council of Medical Research, the Oswaldo Cruz Foundation of Brazil, the Ministry of Health of Malaysia, and the Institut Pasteur of France, with the WHO as a permanent observer. And I mention those names because they provide a proof that the research and development capacity and interest of developing countries is driven by responding to neglected populations and neglected diseases, and can provide a model for collaborative, global, patient needs-driven research, development, innovation, and access for not just infectious diseases of the tropics, not just for pandemics, but for all conditions that cause human suffering and death. There is a potential to leverage the innovative capacities of academia, the private industry, and the public sector jointly using models such as have been created by DNDi, and using policy recommendations that will be highlighted by some of the panelists we have in the webinar today. Our distinguished group of panelists offer both institutional and personal leadership in the fight against neglect of diseases, of people, and of a continent. And so we welcome you all to participate as fully and as vigorously in this discussion as you can. The intention is to drive a reform of global health in the public interest and to use the tools at our disposal, including those that manage intellectual property and knowledge, which is so central to the COVID-19 response, in a way that puts people first at the center now and always of the health process. A couple of short housekeeping issues. We are using the hashtags hashtag TRIPS waiver and hashtag no COVID monopolies to allow you as participants to interact with the session. You can also put your questions into the question and answer box in Zoom. I would like now to introduce our first speaker, Dr. Musa Gama, who is an extraordinary professor of the University of Pretoria and currently a counselor with the South African Mission in Geneva. He's accredited to both the World Trade Organization and the United Nations. He previously worked at the Department of Trade and Industry in the South Africa government and headed the Legal International Trade and Investment Directory. Musa was also previously the South African representative to the WTO trade-related aspects of Intellectual Property Council, so the TRIPS Council, and the United Nations Commission on International Trade Law for Arbitration of the United Nations Conference on Trade and Development. Over to you, Musa.
Spring, thank you very much for that generous introduction. To the audience, good morning, good afternoon, good evening, wherever you are. I'm really excited to speak about the proposal that we put before the TRIPS Council last October, but I find your introduction also to draw out various points that I want to also reiterate as I go through the proposal, and I try to update on where we are and what the various steps would be in the future. And I certainly agree with you that this is not just about what is happening now. It is also about what we do in the future as a continent with aspirations, and whatever we do today will impact tomorrow. And so from that point of view, I would want to commend many of the statements that you made in introducing this particular discussion. Spring, just starting with one of the issues that you raised, and this is the issue of vaccine apartheid, which we specifically mentioned in October, but we have been warning about this actually since February of 2020 and repeated this in the July session of the TRIPS Council. And so from that perspective, we have a very painful history, and all of you know that apartheid denotes a system of institutional racial discrimination. And so if one would look at it from the context of vaccines, it's very clear that the impact of any measures implemented by those countries that have access and the means to deny poorer countries access to vaccines essentially come down to the same thing. And you mentioned the HIV and AIDS pandemic, and for all intents and purposes, this is really the starting point for our discussion around COVID, because as you will recall, in the 80s and 90s, South Africa was really the epicenter of the HIV and AIDS pandemic. And so from that perspective, in the 90s, we wanted to change our laws to enable easier access to medicines that would be available somewhere else. And this was opposed by 39 pharmaceutical companies who opposed the government of the then Nelson Mandela to issue compulsory licenses. And to fast forward, in 2001, the new trade round, which launched the Doha round, development round, as it were, recognized through a statement on TRIPS and public health the essential intersection between intellectual property and public health imperatives. And so it's really there that this story starts, and where South Africa's concerns would still reverberate up until this point in time. And so when we introduced this particular waiver, we had a concern that we would not have access to the necessary means, not only to diagnose, treat, but also to eradicate COVID-19. There also, when we introduced the proposal, we had a lot of opposition from those countries in the north who had production capacity and who would use intellectual property rights in a way to deny access. We had also raised in recent times the issue of so-called charity. Many countries that oppose our proposal have said, but there are enough avenues to ensure that everyone has access. But this is not necessarily correct. Many of the institutions do not provide full coverage, do not provide the type of flexibilities that we need to ensure that our health needs are taken care of. All of us have experienced very, very painful experience in the past of how these rights are applied in a way to deny us equitable access. And so the kind of charity-driven models that we see today are not sustainable. COVID-19 has clearly pointed this out. And if we wanted more sustainable methods and to access, we need to look at a more equitable application of intellectual property rights. And from this perspective, we believe that our waiver proposal is perhaps the first step in getting there. And so in calling for a limited suspension of specific types of intellectual property rights, we believe that we can enable the spare capacity that exists in developing countries to increase production and to ensure that all of us have access to vaccines in the shortest possible time. We have seen the consequences of delaying access on various levels, because the pandemic is not only a health pandemic, it is a socio-economic crisis for all of us. Countries that do not have the means to provide huge stimulus packages are reliant on closing down their economies. The African continent in specific has very large parts of the economic activities within the so-called informal economy, which means that if you close down an economy, if you lock down an economy, people cannot work. And if people cannot work, they do not eat. And we've seen from the statistics published by the World Bank and the IMF, 600 million more people have become nutritionally insecure, having moved back into poverty, steadily reversing the progress that we've had over the last decade. And at least 100 million have gone back into extreme poverty. So this is really bad news for us. And the longer we do not have access to effective vaccines, we have to keep our economies closed and our populations become more insecure. So we have made an argument for the rollout of vaccines because we believe that this will enable all of us to get back to open our economies, to address the nutrition insecurity, the food insecurity that we see, the rising levels of poverty, and this will also enable us to look forward. I think, as Spring rightly pointed out in her introduction, this is not the final pandemic. This is not the final hurdle that we are facing. And so in a post-COVID recovery strategy, we have to build up in a way that is more inclusive, that enables those countries that are most at risk to have access in the shortest possible time, but also to build up our capacities. In the last intervention that we made at the TRIPS Council, we also pointed out that only 10 countries up to date have been responsible for 70% of administrations of a vaccine, which means that 130 countries have not yet had even one administration of any of the vaccines that could be available. This is unacceptable in a globalized world order that we see today. And so given these particular discrepancies, one of the big questions that we have to answer, not only in this seminar, but in going forward, is how do we address the so-called strategic vulnerabilities that we have? Spring pointed out that 80% of our medical needs are met through so-called importation. One of the things that we see many countries now doing, the European Union is doing it, the United States is doing it, they're reshoring manufacturing capacity, they are reinvesting in domestic capacity to produce. And this is a fundamental requirement for Africa to meet its developmental needs and goals. As we look at the SDGs, as we look at the importance of reaching our health goals and our economic development goals, it is important to start to think how we construct a mechanism that deals with not only COVID, but any future challenges that we may have. So irrespective of what happens with the waiver proposal, we need to be ready and we need to prepare ourselves. And it's very clear, the only way that we will do this is to have local production, to have local collaboration. We do have the capacity, and I think colleagues that follow will essentially point this out. I want to close by encouraging everyone that's on the call today to really reach out and to put information in the public domain, because this is the only way that we've been able to come so far. We are very grateful to civil society for the assistance and the help that they've given us to negotiate in the room, and we continue to be dependent on these initiatives because, firstly, we need to keep governments to account. We need to emphasize the legal rights and obligations of government to engage in a good faith effort. The TRIPS agreement recognizes this particular tension between private rights as intellectual property rights and public interest, and the obligations of governments to act as agents of change and mediators. And so we do not think that that balance has yet been achieved. So we need to keep our governments to account. We also know that no right is absolute. We can limit rights under particular circumstances. We believe this pandemic is such a circumstance where we need global cooperation. The only way we will defeat this virus is if we cooperate and if we put the mechanisms in place to enable us to have access in the shortest possible time. So we need to address the catastrophic market failure because of the ability of only a few monopolistic producers to decide whom they provide licenses to and to impose legal restrictions on the number of vaccines, for example, that can be produced, and also putting geographic limitations on where this can be distributed. And so from that point of view, we hope that the waiver proposal can open up the ability to address and produce, get our local production up in the shortest possible time. But in the long term, there are seminal issues that we have to address if we want to reach Vision 2063, the Africa we want. So on this note, I will end to say that no one is safe until everyone is safe. We've seen the mutations make the efficacy of current vaccines less. And so from that point of view, the more we allow the virus to mutate, the greater the possibility that we will have more virulent mutations. And this compromises every one of us, not only in developing countries, but also in developed countries. And I think this is a message that has now started to dawn. We have much more sympathy in the room, but in the end, we have to translate this sympathy into action. And we believe the action should be that we pass this waiver in the interest of humanity. We have many more backers. The African group has signed on, the LDC group has signed on, and in the very near future, we also hope to sign on one or two other groupings, and this will give us at least the numerical backing to ensure that we push the discussion to its logical conclusion. I leave it at there, Spring, and very grateful for the opportunity to speak about the waiver proposal, but also very honored and privileged to continue to be part of this webinar and to interact with everyone, including through the chat and also in the Q&A session, which is to follow. Thank you.
Thank you very much, Mustaqim. And so this is the first of what I expect will be many rallying calls in this conversation. We need to look at how to stimulate local production, or if we can put it better, a diversification of production of health technologies and especially vaccines, so that all continents can access the vaccines that are needed for the population, especially in the face of reshoring. That is an immediate term need that we have. We have an immediate and medium term need to address the additional socioeconomic impact that this crisis is posing. People are going hungry now. People are going to go hungry in the midterm. Acute malnutrition is going to turn into a chronic problem that will impact development. We all know what the implications of undernutrition are for development. We also see the need for a strategic reorientation that is not one based on sympathy and charity, but on robust health policy founded in the human solidarity, but also in the understanding that we will not achieve the SDGs or the Africa that we want by 2063 if the COVID pandemic continues to be addressed in a way that is disproportionate and leaves out a disproportionate number of countries. 130 countries being left behind is, as Mustaqim has said, simply not acceptable. So in turning over to our next speaker, who will reflect on the myths, realities, and the opportunities afforded by the TRIPS waiver, I'd like to introduce to you all Dr. Hu Yuan-Chong, who is a lawyer and postdoctoral research associate at the School of Law at SOAS, and who works as a senior legal and policy advisor for the MSF Access campaign. She focuses on access to medicines and intellectual property, and has provided legal advice to multiple jurisdictions, including India, South Africa, China, Brazil, the US, South Korea, and the European Patent Office. She is also widely published on the topic of intellectual property and access to medicines, including a co-authored article on medical patents and the rights to health, from monopoly control to to Open Access, Innovation and Provision of Medicines. That was published on the German Yearbook of International Law in 2019. She has conducted consultancies for the Asian Pacific Regional Office of the United Nations Development Programme. She works with MSF, and she has worked with the Third World Network on patent and access to medicines issues, and for Save the Children on post-2015 development policies. She interrogates the role of expertise and professions in norm making, and aims to explore the alternative conceptual frameworks for biomedical innovation in contrast to the patent-centric paradigm. So I will hand over to you now, Yan-Chong. Thank you for joining us.
Hello. Thank you very much, Spring, for the introduction. It's my pleasure to join this seminar. So I will start sharing my screen and share some of our observation from MSF on the current process. Okay. So I will start by, Mustakin and Spring has very nicely tied the issue and why it's at stake for the current struggle. So I would like to just quickly connect to the history and showing how MSF as an organization came here and how the present struggle really lead us back to the historical inquiry that we have been trying to fight for more than 20 decades. Two decades. And then for MSF, we have been following the access to medicine issues, challenging the injustice that's brought up in the current global system when the charity model is still taking the central stage, and the demand for change has not yet happened. Even we have went through many tragedies when private monopoly are costing people's life. So in the current struggle, as Spring and Mustakin mentioned, at the global level, we really see the growing demand and support to the current Waiver proposal, which reflect the bigger call to really interrogate how this current system is run in terms of how the life-saving medical product and the technologies are developed, produced, and delivered to people who need them. When it's come to the MSF work, we have been responding to COVID-19 since last year in more than 60 countries and providing the care and treatment, but also to make sure essential healthcare are not interrupted. To date, we still see the frontline health workers in many countries where we work, especially in Southern African country. We have the dedicated COVID response teams are struggling to secure access to many medical tools and struggling to make sure priority access to vaccines are guaranteed for frontline workers so they can continue providing care to patients and people. And well, at that same time, goes without saying, we see how the inequality of vaccine access has been unfolding when wealthy countries are holding the majority of the supply. So we are really seeing the structural barrier facing us when it's come to IP and technology issues. When R&D funded, R&D for biomedical funded by public finance and supported by majority by the public are continue controlled in the hands of private sectors. We have a normative barriers when the inherent limitation of rely on companies' willingness does not really deliver equity and universal access on a timely manner. And we see the limitation of the current legal tools provided by international law and the national law that does not provide sufficient empowerment for government to step in and protect the health sufficiently. And we see political barriers when there's still a sharp division between developing countries and developed countries when it's come to the common understanding of protection, human health as ultimate priority as a global community. And we also see the practical barrier when how to overcoming IP become not so easy in the emergency situation at the global level. That leads us to follow some of the myths and realities when the TRIPS waiver proposal was negotiated in Geneva, when some of the common claims used by the country who are blocking the process and the pharmaceutical industry at large are causing problems to us. So one of the central argument is that IP isn't a barrier, and there is a lot of development coming to the pipeline. But then both past practice and current experience of the pandemic shows the contrary. We see the emerging pipeline of therapeutics, many of which are under patent protection or potentially could be put under the repurposed drug protection through second medical use patent and other IP. And we see company continue using limited voluntary license on some of the candidate medicines, and then the growing number of patent portfolio in many developing countries on some of the pipeline therapeutics. We see vaccine being used as one example for pharma to claim that IP is an issue, whereas production and supply are the major issue. So we acknowledge supply and production are the major issue for sure, but it is also not true to claim IP doesn't play a role in hindering and restricting the current landscape and the future prospect of vaccine supply. We see a huge number of background technology of current vaccine for COVID-19 under patent protection and private control. And we see the difficulties of overcoming the secrecy of the vaccine deals and the secrecy of clinical data manufacturer know-how, which if published could have helped many developing country producers to start preparing for production and scaling up supply quicker. So we don't really see, the claim of IP isn't barrier is really holding the water. And other claims we heard, such as IP is essential for R&D development in COVID, and as another palette, as Musa and Shrink mentioned, this is not entirely suitable in the current situation when the current R&D for COVID medicine and vaccines are largely funded by public funding, and government and general public are playing an essential role of driving the R&D so far. And government actually also taking the risk out of the private sectors, generating securing the manufacturing, and even taking away some of their liabilities. And the voluntary license have been used in a very restricted manner and lacking of transparency. So far, we haven't seen any promising transparency in terms of vaccine licensing and the therapeutic licensing to guarantee the essential technology are openly shared to enable global production and supply. And TRIPS reliability are embedded in TRIPS agreement. However, it has shown a kind of limited effect in addressing the global challenge when we need many countries to take action immediately altogether and to overcome the IP and monopoly barriers on different components of medical products at the same time, so they can easily come up to collaborate, share the capacity, and scaling up supply. And there has also been historical suppressing from some of the trading partner for the developing countries such as the US and EU, and discouraging for a very long time developing countries from using those flexibilities. And then the COVAX and other global mechanism for delivering vaccine has been, on another hand, restricted precisely because of the vaccine nationalism led by wealthy countries by holding the majority of the supply. So when it's come to the capacity of a developing country, there's also an understanding that there's no way, developing country can do anything by themselves other than waiting for the charity. We also don't think this is true when many developing countries do have capacity and can help themselves on different aspects when it's come to production and supply. So really, we look at a historical portal at the moment when the waiver proposal reflected a much bigger challenge we are facing in the global health. in terms of inequality, and how life-saving technologies remain controlled based on private interests, and the lacking of effective mechanism globally to ensure the technology are shared, transferred, that can benefit to all. So the waiver proposal for us provide a unique opportunity to interrogate how the present challenge can be met, can be addressed, but also open the opportunity to have the longer term inquiry, how the current system need more profound reform, that the action and strategies in preparing for the future pandemic could start from now for low and middle income countries in the future. So I will stop here and then look forward for more exchange with everybody. Thank you.
Thank you very much, Chong. Just to summarize, you've reiterated the points that were raised also by Mustaqim, that there continue to be structural, normative, political, and practical barriers in the way that which intellectual property is managed that result in it not being managed in the global public interest, but being managed for the benefit and being exploited also for the benefit of a few. There are additional particular issues about the lack of transparency, secrecy of deals, and sharing of knowledge and data, which limit the potential of developing countries, even though that potential is strong, and even though there is a strong interest in acting to produce health technologies to respond to the pandemic, that the processes of lack of transparency, secrecy of deals, clinical data, etc., and the de-risking of private innovation without a clear return on investment for the public that is funding this in both social and economic terms continues to present a challenge. The waiver presents a unique immediate opportunity to address shortages in production and supply, but as part of a basket of policies that will be required for profound reform of the system in the long term to make all countries resilient to future pandemics. So thank you very much for that intervention. Our next speaker is going to give us the people's perspective from Uganda, which is an LDC, as many of you know, but which is also a country that has a strong advocacy movement and a strong interest in securing human rights approaches to health. Dr. Moses Mulumba is a lawyer. Mr. Moses Mulumba, he reminded me, is a lawyer with a special interest in international human rights, global health, and the development dimensions of IP law. He's the founder and current executive director of the Center for Health, Human Rights and Development. And for the past 15 years, he has led and been part of advocacy campaigns on access to essential medicines, including on legal reforms in IP laws in Uganda and the East African community. He is a former board member of the Uganda National Drug Authority and continues to be a strong advocate for progressive drug policies that enhance access to essential medicines in low-income countries. And Moses is going to talk to us about the role of civil society organizations and the impact of the TRIPS waiver on patients and communities. Over to you, Moses.
Thank you so much, and thanks panelists and those that are following the discussions. So about a few days ago, one of the dailies in Uganda came up with a headline where it was making a statement that the president and those that are close to the president had been able to get the vaccines before we officially got the vaccine in Uganda. The next day, the ministry responded and said that whatever was being reported on was not correct. In the response, the ministry indicated the strategies that are existing in Uganda for bringing vaccines. This includes some of the global initiatives like the COVAX initiative, but also indicated that China had promised to give Uganda some doses for the vaccines. As I was thinking about this and swallowing what it actually means, I came across another headline in the US where two women went ahead and changed their documents, their registration documents, to actually indicate that they were much older than they were. So these two ladies were trying to access the vaccine much faster than the rest of the people that wanted to access the vaccines. I think these two quick stories are capable of demonstrating very many things, but I will focus on what they actually point to us when access to a very essential life-saving commodity is limited. This is when we see dominance coming at its best. It is at the time when hegemony is actually demonstrated. But people will do whatever is within their powers to actually ensure that they access this particular medicine that they do need. Any illegality will not be a challenge for them to actually be able to access the medicine that they want to access. Indeed, I think the women received a pass on a punishment of trespass. So we are in a situation where everyone is fighting for survival. But I want to let the world know that in moments of survival, those that are most vulnerable suffer the most. COVID-19 is here. It's certainly going to be with us for some time. So we need to think about short-term strategies, think about medium-term strategies, and also think about long-term strategies. I think that the strategies that the world needs to look at should move away from short-termism that we have always seen of fronting today's profits and forgetting what this actually means. It's not surprising that right from 1978, when we had the Almata Declaration, investment in drugs and pharmaceuticals has been emphasized. It's not just emphasized for sophisticated things like COVID-19, but also basic things like primary health care. So the TRIPS agreement as it is gave some options that were short-term. From 1994 to date, someone may think that close to 20 years is very long, but I think what we are seeing is that options for accessing essential medicines cannot be given a timeline. COVID-19 has also demonstrated that we cannot talk about capacity, that certain countries have reached a certain level of development, and therefore, once they reach here, we must be complying with some global rules. In my view, as I'll be concluding later on, I'll be arguing that some rules have to be forgotten when matters become matters of survival. We do advocacy every single day, and we do this advocacy on the African continent. This continent is now second to Asia in terms of the global population. Africa is almost 17% of the world population. But when you think about how much it produces in terms of medicine, it's less than 3%. I don't know if we've reached to surpass the 3%. But you can clearly see that while the continent is the second in terms of population burden, it is actually at the bottom in terms of production of essential medicines. We've spent so many years with the HIV/AIDS pandemic, and the same things we are discussing today were discussed 20 years ago. But the result is indicating to us that the African continent still imports 80% of the virus, the medicines for HIV. And that's overall the picture. In countries like Uganda, we import 90% of some of these, and even those in the region in East Africa where we think that there has been some level of development, like Kenya, which is classified as a developing country, they still import 72% of the medicines that they need on their essential medicines list. Now, this is happening in a situation where the continent is dealing with so many challenges: infrastructure challenges, health systems challenges, supply challenges, high debt challenges, also internal challenges like corruption and the leakages of drugs which come in. I think that on this burden, we should not add a burden where the world has the option of reducing the burdens of Africans. I'll still look at Uganda in terms of pharmaceutical production. We had about 14 industries registered a few years ago. These were plants that are approved by the National Drug Authority to manufacture medicines. 9 of them were operational, and just 1 of them is GMP compliant. There are so many testimonies of people running away from doing pharmaceutical manufacturing because of challenges that are not going to be dealt with even in the next 20 years. I still remember testimony of one of the manufacturers in pharmaceuticals who actually found it much better to close the pharmaceutical production line and open up a fruit drink juice factory and biscuit production because it was more productive to them. And this demonstrates to us what happens when you leave the private sector to be the major provider of the essential medicines that we need. Private sector dominance is all over. The 90% that I've talked about of importation, close to half of this, I think more than half of this is importation that is done by the private sector. We have seen in COVID-19 that the production of the most basic things, test kits, masks, are not actually happening within the country. And if they're happening, they are very little. But the private sector had invested in the production of alcohol much more than the pharmaceuticals. So the production of sanitizer is not a problem. We are not importing any sanitizer because this is where the investment has gone. Part of the problem is because we left this sector to the private sector to determine, and the private sector always is directed by profits, not public interest. Where we have seen the public sector play a role in pharmaceuticals, I think some magic has happened. The only pharmaceutical company I talked about which produces medicines is Quality Chemicals, which is a venture which came up because of the government of Uganda. Quality Chemicals, a private entity, and Indian firm, Cipla, came together and established this firm. But what happened to motivate this to happen is interesting. They received free land. They got a tax-free setup on whatever they brought in to set up the factory. They had a 10-year tax holiday, and they had an assurance that for the next 7 years, $30 million worth of purchase of ARVs was going to be got in Uganda. Now, this motivated the setup of this factory. And as I speak now, ARVs are not just supplied in Uganda, but also in the region. But this has taken very many years, and it has taken a long time, and support not just of Uganda internally, but also the solidarity that came with the South-South cooperation between India and Uganda. Part of the big challenges that we still face is intellectual property. Things are changing really fast. Personal protection equipment for COVID-19, much of it is still under IP protection. Medical masks, if you need the efficient ones, some of them are still under protection. And it's not just in patents where actually we had been told that if we get exceptions of pharmaceutical related things in patents, we'll certainly be able to do magic. Some of these are covered under industrial designs, some is copyright, and we have already legislated at the national level, and we can't turn back. We have already tied ourselves in terms of that policy space on utility models, industrial designs, and copyright. So the waiver is important, but the conversations I think also need to move away from the waiver and think about the general extension that Chad has put in as a request. We need to think about how we frame the conversation moving forward. I think that the state obligations are very important, but these state obligations must not be restricted to national state obligations. We need to look at the global social contract. And within this global social contract, we need to actualize the global declarations we have made in sustainable development, in all these international human rights instruments to actually be able to make things happen. Within the human rights framework, the right to life is under threat, the right to health is under threat, but we also need to make meaning on what this right to enjoying scientific benefits actually, what it means. We need to see countries, not just at the national level, but at the global level, be respectful. They need to avoid interference from what efforts of other countries in protecting of their own citizens in the face of COVID-19. We need to see this obligation on protection being actualized. How do you regulate the private sector? How do you set the new roles? I think we need to reclaim the state. The state, not just at the national level, but also state need to look outside their own national goals, to look at the global solidarity in this obligation of protection. Nationalism is not a way to go. Focus on profits is not a way to go. But most importantly, we need to look at the focus on fulfillment. How do we move ahead to fulfill? Because countries in like Uganda, we have put the exceptions that we are told can work. We've spent the last 15 years putting exceptions, not just at the national level, but also at the regional level. But it is actually come out very clearly during the pandemic that these exceptions without real action and solidarity of countries globally are empty. We need to have them, but we need to also be mindful that public health keeps changing. In summary, I think that practical things over and above the waiver, or things that can happen with the waiver that are very important, include the fact that I think if we get the waiver, our work on South to South cooperation is going to be actualized. We have seen relationship between India and Uganda. We've seen relationship between China and Zimbabwe. We've seen relationships between China and Kenya in the pharmaceutical industry. And these have made magic. And I think we need to look at this waiver, not just as enabling people to receive medicines, but also promoting South to South cooperation. I think that vaccine diplomacy, which we are beginning to see, is going to be important, but it needs to be much more organized. We've seen the delegation from China coming to Uganda and promising that they are going to be delivering. But China is also influential in Thailand. I've seen China all over the African continent. They are not actually speaking, but they are using vaccines as a diplomacy tool to be able to also capture the other things that are being negotiated as part of diplomacy. But as I've indicated, we are not going to be able to finalize things if the general extension is not realized. We need to think about global solidarity. What does global solidarity mean? It's not about domestication. It's not about, nationalism. I think solidarity needs to be actualized. When do we actualize these global consensus documents that we are talking about as part of solidarity? What have we learned from history? The HIV/AIDS movement and the HIV/AIDS fights for medicines already demonstrated the same things we are going through. When do people demonstrate global leadership? I think global leadership is way beyond the colonial approach of leadership, but it's about meaningful tenets of globalization that we have seen over the years. And this communicates the fact that you cannot resist countries that really want to access medicines to save their citizens. There is no leadership at all when countries go ahead and refuse to have waivers granted. I think for now, I'll stop there and wait for the rest of the conversation. Thank you very much.
Thank you very much, Moses, for the plaidoyer for global realization of the global social contract for states to realize that their obligations extend beyond their national boundaries, and to the need for the international community to act in real global solidarity and show real global leadership that is not modeled on colonial or externally driven approaches, but allow countries agency in using the tools that have been placed at their disposal to achieve and to secure the health of their populations. You've reminded us of the several global instruments that simply need to be actualized: the right to health, the right to life, and importantly, the right to benefit from scientific progress of all people everywhere. These are enshrined in UN documents, as you generously remind us. And then to also consider that the general extension of exceptions to the for the LDCs to excuse me, to the TRIPS rules would provide an additional enabling environment for affording access to health. You tell us that there's magic in the waiver. You tell us that there is magic that that opens the opportunity of South-South collaboration to drive pharmaceutical development that requires the public sector to resume its role as the leader in this, and to find those partners from the private and other sectors who are willing to work together to create this enabling environment. And finally, you remind us that we run the risk of introducing both individual and collective corruption of health systems and health processes if we do not afford equitable access to health technologies. Our final panelist, before we go into the question and answer section of this seminar, is Dr. Ahmed Ouma Ogwell. He's the Deputy Director of the Africa CDC, whose mandate it is to support the 55 countries of the continent in addressing their public health needs and to addressing disease threats. The Africa CDC is the public health institution of the African Union, which has been mentioned today, has already endorsed the waiver. Those of you who know Dr. Ogwell also know that he has worked in global public health for many, many years. We will say decades, but we won't put a number on how many decades those are. He is a leader, an international civil servant who has worked on the Framework Convention for Tobacco Control, for the prevention and control of non-communicable diseases, where he was advising the global coordination mechanism in the office of the ADG for NCDs and mental health at WHO in Geneva. He worked at the WHO Regional Office for Africa. In Kenya, he was a founding director of the NCD's department in the Ministry of Health. He also established the Office for International Health Relations. He guided the Africa Group participation in the Global Strategy and Plan of Action negotiations, and in fact, with South Africa and a number of other countries, initiated the entire debate about intellectual property, public health, and innovation at the WHO, which later became a trilateral partnership. And he is now leading the COVID-19 response of the Africa CDC together with Dr. John Nkengasong. We have seen incredible Pan-African solidarity in the response to the pandemic. And now he's going to tell us what the TRIPS waiver means in helping the Africa CDC actualize its mission on behalf of the people of Africa, but also helps Africa play a role that it has called for in the innovation and access of all people everywhere to health technologies. I hand over to you, Ahmed.
Thank you very much, Spring, for those very kind words. And good morning, good afternoon, good evening, colleagues, wherever you are. It's indeed a pleasure to be on this platform today with you in this seminar to talk about the TRIPS waiver that is being debated currently at the WTO. Let me start by quoting Martin Luther King when he says that in the end, we will remember not the words of our enemies, but the silence of our friends. And this is very poignant in our current situation. Reflecting back on the HIV/AIDS crisis in Africa, we lost over 12 million Africans in 10 years between around 1996 and 2006. And during this time, we actually had in the markets drugs for HIV/AIDS that would have saved the vast majority of those 12 million Africans. It's a situation that is a catastrophe, and we do not want to go back in that direction, losing people simply because someone holds a license for a life-saving therapy or vaccine, and they keep it unless you have the money to be able to buy it. This we will not accept, and as Africa CDC and Africa Union, we are doing everything in our power to ensure that this kind of inequality does not take root during this time of COVID-19. But why has Africa lagged behind in as far as the various types of COVID-19 tools are concerned, including the vaccine? When this pandemic first hit Africa, February 14th, in the year 2020, the supply chain for all types of health products that will be useful in addressing the COVID-19 pandemic, the supply chains were totally disrupted because for whatever reason, those countries that do most of the manufacturing of the commodities that we need were more or less the first ones that got the outbreak growing within its population. And so as Africa, we remained holding the very short end of the stick, not having manufacturing capacity, and therefore having to scramble across the world trying to get the very basic necessities for protecting ourselves, for testing, indeed for managing those who had COVID-19. It's an experience that as Africa CDC, sitting here at Africa CDC, was very, very painful, knowing that Africans are not lazy. We have beautifully bright minds. We have very focused and passionate professionals who only needed a little bit of investment in equipment and facilities to be able to manufacture some of these things that we need. It's a lesson that we have taken extremely seriously, and we are going to address it in the coming months, as you will hear as we go along. We are very keen to ensure that local manufacturing of everything we need for pandemic preparedness and response is being manufactured here on the continent. And we are very keen that our friends would support this. And we are very keen that we'll be to tell everyone that will be listening, not just to the words of our enemies, but the silence of our friends. So when we look at the tools that we need and the absence of their manufacturing on the continent, it meant that we had not only to scramble, but also to initiate a thought process of how can we be able to get some of these materials being manufactured on the continent. We have progressed in that end. The big challenge still remains COVID-19 vaccines. And COVID-19 vaccines remain a problem because they're a new product in the market. And those who are producing these vaccines do talk about public health good, but the good is not for other people other than themselves, and that is why we see vaccine nationalism growing. The public is not really a global public, but it is the public within their own borders. And in this situation, the word global then loses meaning. And if we lose meaning where the word global is concerned, then we are going to be in a lot of problems in the years to come, because those who hold raw materials may end up not sharing them. Those who hold knowledge may end up not sharing it. And those who have facilities to manufacture certain products may also end up not allowing those to go beyond their borders. So it's a very dangerous and slippery slope that some countries have started walking. And we hope that they will step back and appreciate that this world is one and we are all in it together. And if we do not make vaccines available in a timely manner, in the quantities that are required, then we are not going to be able to bring the pandemic under control. And so long as the virus is circulating in one part of the world, another part of the world will always be at risk. Now, due to the shortages that we faced during those days of 2020, what we did as Africa CDC and the Africa Union is we established the Africa Medical Supplies Platform. This is a midway, because we cannot manufacture due to the investments that are required. We then established a one-stop shop where COVID-19 commodities and materials could be easily available to African member states. And we went out negotiating with those who manufacture these commodities, and we placed them on that platform at a negotiated rate. And it made matters a lot easier for those who wanted to support Africa in its efforts against COVID-19. But not so for vaccines. And this being the latest tool and one of the key tools in combating this pandemic, it is extremely crucial that those who hold licenses to the various vaccine candidates that have been provided with emergency use authorization, it's important that they appreciate that providing an avenue, and I speak here as an African, providing an avenue for Africa to be able to have manufacturing happening on this continent, and therefore making the vaccines more available and quickly, is good not just for the companies, but it is good for public health, and it is good for future relationships as well. And we keep on encouraging these companies not to wait to be forced to provide licenses, but in effect, it would be a lot easier for them if they negotiated early before some of these measures take the turn of being forced. And being forced is usually not a very good thing, neither is it pleasant. Now, when we look at the implications of this proposal that has been brought forward by South Africa and India and has been joined by many, many countries now, I would like to first reflect on the fact that its seriousness has been discussed at the highest levels on the continent. Our heads of states during the Africa Union Assembly in February this year, last month, they met, they discussed, and they were unanimous in their support for this particular proposal. And they have urged all African member states, the 55 of them, not only to join in being a sponsor, but to fully support and encourage others around the world to support this particular proposal. And the proposal is going to open a very important door for commodities to be available. When we talk about vaccines, we need to remember that there are many other commodities that come together to make it possible for vaccination to occur, whether it is specialized needles, it is specialized syringes, tools for data collection, for supply chain management, especially those that require very low temperatures, etc., training. So that whole package, if these tools are made more readily available on the continent, it will open a very huge door for the pandemic to be brought under control quickly, and for the whole globe to be able to adjust itself back to not what used to be, but at least a much better a level of normalcy than what we have now. So this proposal, we support it fully, and we urge those who are our friends to also support that proposal and allow for the flexibilities to kick in and for these commodities, particularly vaccines, to be more readily available for Africa, because then we can be able to prevent and contain the pandemic on the continent. Exporting, importing is a very lengthy process, and very often you find that those manufacturing facilities do not have the capacity to produce enough for the whole world, while on the continent of Africa we have many facilities, at least 10 by our count, that can be able to be repurposed and used for vaccine manufacturing. In fact, here I may add that Africa has one of the largest manufacturing infrastructure for manufacturing vaccines for animals. For those of you who are technically leaning, vaccines for animals are the same pathogens when you look at vaccines for human beings. And what is required is some tweaking to ensure that safety and efficacy is at the level that is appropriate for human beings. But a lot of those can still be able to be repurposed to ensure that we have an expanded network of facilities for manufacturing vaccines on the continent. So when those licenses do come through, Africa can be able to start manufacturing in a very short time indeed. So we are encouraging not just the African governments, but also our friends to speak up, because we will be remembering their silence if they don't. Now, some lessons that we have learned during these last 14 or so months when the pandemic has been with us in Africa. The first lesson we've learned is we must work together. And to this end, our heads of state have shown the way. They have met at least 14 times just to discuss COVID-19 over the last 1 year or so. And this has been extremely critical in ensuring that at the highest levels on this continent, COVID-19, its preparedness and response is being discussed and being provided with the attention that it deserves. And we as Africa CDC coordinating the response of the continent, we have seen the value of policymakers and especially leaders coming together to discuss, agree on what needs to be done, and then again together implement those items that have already been agreed upon. So coming together is a very important lesson that we have learned. And during this time of debating this TRIPS waiver, it is even more important that we come together and we speak with one voice and we provide and lend our support together. That way, this particular proposal can be able to pass. The second thing we've learned is, of the many things, the second thing we've learned is we must do things quickly. And if you look at the amount of time that it has taken for the current vaccine candidates to actually come through and achieve emergency use authorization, it tells you that we are becoming better and better at developing and eventually making vaccines available to the general public. And this is not by accident. It is because there are professionals who are doing good research, and this research is then being turned into products that can be able to help humanity to control this particular pandemic. Speed is of the essence. Whenever something needs to be done, it should be done now, and not we wait and talk about it for months and years before action is taken. And it's in the same way that this particular proposal is important, that to be able to do anything at speed, we must increase the network of facilities that are actually manufacturing vaccines. For us to be able to bring the pandemic under control, we need to reach herd immunity in the shortest possible time so as not to give opportunity for variants to come up that are going to create a lot more problems for the vaccines that we have in the market currently. So speed is of the essence, and this proposal opens up many more facilities that can be able to produce more vaccines and make them available for the rest of the world to be able to, particularly us in Africa. And not only vaccines, including test kits and other essential commodities for combating the pandemic. The third lesson that we have learned is that we need to use the resources that are available first before we go seeking for resources outside. And a good example here is in the beginning of this pandemic, we did not have laboratory capacity for diagnosis of SARS-CoV-2. By the time the end of February came, we had 2 laboratories on the continent that could do it. Using these 2 laboratories, we were able as Africa CDC to build the capacity of thousands of laboratory scientists across the continent, so that they were able to understand how to do laboratory diagnosis for SARS-CoV-2. Indeed, by the time that June came, the whole continent had the capacity, each and every country had the capacity to be able to do diagnosis. And without diagnosing, you will never be able to tell how much of a burden you have with COVID-19. So using the resources that you have to expand the space of knowledge, skills, and action has shown us that we can be able to achieve more just by using what we have as we expand it and go along. The fourth and last thing that I would like to share, there are many experiences that we have, many lessons that we have learned, but I'm just picking out these 4. And the fourth one is that we must remain disciplined as the public. And discipline comes from good knowledge. And good knowledge is always clouded by a lot of rumor and fake news. And good knowledge, we must seek it only from those institutions that have the confidence of the public. You don't just pick anything that you see in the internet or on social media, and then you take that as the truth. Discipline came because the governments were providing the correct information. Discipline came because continental organizations like ourselves, regional organizations, were providing information. And members of the public will then use this information to be able to protect themselves and do that which is right. So engaging members of the public is that fourth lesson that we learned, that you must engage them with facts, you must engage them regularly, and you must provide a lot of transparency in the way in which you're documenting the pandemic, in the way in which you're sharing information with members of the public, and in the way in which you're responding to their concerns, questions, and of course, appreciating their proposals when there are some. So engagement with members of the public in a transparent and factual manner helped to provide very important and key tools for members of the public to be able to protect themselves. I would like to say finally that it is always, as Nelson Mandela says, that it's always very difficult. It always seems impossible before it is actually done. And we can be able to do what is right for public good. And this is going to be done by member states stepping up to the plate, taking up their responsibilities, and ensuring that those waivers are actually granted, and we start producing particularly vaccines, but indeed all other tools for COVID-19 in larger numbers, in a faster way, so that we are able to bring this pandemic under control and go back to what is now called the new normal. As Africa CDC, we will continue to support the process with all the technical information they need. We provide updates twice in a day to our member states, and we will ensure that when they go in to discuss and negotiate, they have all the facts at hand. And one very big fact that they must go into these negotiations with is that if we do not get those licenses, if we don't get those waivers, then Africa will only get the trickle effect of the vaccines and other COVID-19 tools, and we will not bring this pandemic under control as fast as we need to be able to protect our economies, which were hit very, very hard by the pandemic in 2020. We want 2021 to be different, and we want that our member states and our friends go out there, speak, support the waiver proposal, and we can be able to get the COVID-19 vaccines and other relevant tools more readily available to Africa than it is now. Thank you.
Thank you very much, Dr. Oguel, for that comprehensive overview and for sharing with us the progress, the very exciting progress that the Africa CDC is making, and for that strong call to our friends, and we shall know them where we see them all over the world, to share their products in the immediate term to respond to the immediate needs, especially vaccines, but also to share their knowledge, their licenses, and to allow the African continent, to allow us to mobilize its capacity, its skills, its ingenuity, and its determination to itself produce and share resources, to extend the resources at hand and to expand them to everyone who needs them, and to continue to engage with the public in a factual, transparent way, so that and in a way that shows that we are making progress on their behalves, so that they're not susceptible to the infodemic, as it has come to be called. So on your last call to move so that policy speed matches the scientific speed with which new technologies have been developed, I would like to turn over to our audience for just a couple of questions, as we don't have very much time. And the first question is in the chat. It's a bit provocative. It goes to Mustaqim, and it says, isn't this just going around with a begging bowl to the West yet again? Should we not rather be talking about developing Africa's pharmaceutical manufacturing capacity? I mean, I think some of this has been answered in the presentations, but perhaps you would like to reiterate exactly why the TRIPS waiver is not going around with a begging bowl, or if it is, how it can be, I don't know, made less of a dependent model.
Yes, thank you, Spring. I think I tried to answer the question in the chat box, but very important. People always see the barriers to production as physical barriers, but our experience has been that if you wanted to produce something, you have 50 underlying patents that prevent you from doing so. And as I indicated, intellectual property rights are not purely private in their nature and in their enforcement and in their use. And so under these circumstances, it is legitimate to limit those rights and to make the information available. We find many instances where the United States invokes their Defense Production Act and actually expropriates patents, gives it to the military to produce particular types of products. In recent times, masks. I think they've also activated it for various vaccines. So if we take that example, if we take steps to limit these rights, this is not begging. I think it's taking our destiny into our own hands and enabling our local production capacity to be activated. One of the things that we have to decide very clearly as Africa is to make our to make a declaration of independence, and that really means that we have to act and invest in the right areas. Now, the global model for health and access to health has been, well, you know, if there is someone in the world that produces, why do you want to produce yourself? And the answer is, well, there's many reasons why you may want to produce yourself, including the issue of doing by learning, access to knowledge networks, sharing of information, and in many cases, the privatization of public knowledge in our public institutions is really, really disconcerting. So in the end, I think it's a combination of different things, but long story short, the waiver really is just an indication that we need to act on things that we already know. We already know these things, so let's do it. And the only way we're going to actualize this is learning by doing and sharing. And this is what the waiver really enables, a large-scale sharing of information so that all of us are able to act in an appropriate way, given our relative circumstances. I leave it at that, Spring.
Thank you very much, Mr. Kim, and I hope that answers the audience questions. I'm very conscious of time, and I want to give enough of it to our final speaker and co-host, Dr. Monique Wasuna, who is the director of the Drugs for Neglected Diseases Initiative Africa Regional Office. She's a physician, a specialist in infectious disease and tropical medicine, and the founding chairperson of the Leishmania East Africa platform, which promotes clinical research and capacity building for this neglected and very deadly disease. Dr. Wasuna was previously acting director and chief executive officer of the Kenya Medical Research Institute, which was also a founder member of DNDi. She holds a Bachelor of Medicine and Surgery from the University of Nairobi and an MSc and PhD from the London School of Hygiene and Tropical Medicine. She's also a diploma holder from the Tropical Medicine and Hygiene from the Royal College of Physicians in London. She is a member of numerous expert committees on clinical trials, on bioethics, and her research interests focus primarily on neglected diseases. She's been a principal investigator in a number of clinical trials that have been running from the African continent. She's well published in peer reviews and is a former member of the International Bioethics Committee of UNESCO. Monique is also coordinating the DNDi-led anti-COV efforts on the African continent to look at new therapeutics for addressing COVID-19 pandemic. I hand over to you, Monique.
Thank you very much, Spring. Good morning, good evening, good afternoon from wherever you have joined us. I trust that you have enjoyed participating in this webinar. So I have the pleasant duty of thanking you all for sharing your time with us. So first of all, a special thanks to you, my sister and a friend, Spring, for your excellent moderation of the webinar. I also want to thank our eminent panelists, my good old friend, Dr. Guel Ouma, as well as Dr. Hugh Yon, Mr. Gama, and Mr. Moses Mulamba. Really, really thank you very much for the excellent presentations and for sharing really your thoughts on the implications of the TRIPS waiver for Africa. So a big, big thank you to also the participants who have tuned in to this webinar. Again, really thank you. Without you, we wouldn't have this webinar, and also without the panelists, we wouldn't have the webinar, without the moderator. So all of us, we need really to appreciate each other. So also would like to really recognize the role that MSF and DNDi have played in putting this webinar together. So a big thank you to them too. So I like, with the time that have been given, also to state our position as a Drugs for Neglected Diseases Initiative in relation to the TRIPS waiver. So as DNDi, we believe that during this global pandemic, governments must ensure that the poorest, the most vulnerable, and those at the highest risk are guaranteed timely, equitable access to the fruits of the scientific research. So therefore, there is need for scale up and access to all the new COVID-19 technologies, including treatments and diagnostics. African governments must act now. We've heard from Dr. Guel that really they're doing their best, they're acting, they've already met 18 times this year, I mean, for a period of 1 year. So really we acknowledge that. So yes, we must, government must act now to enable sufficient production of these technologies and create additional production capacity through technology transfer and create additional production of the technologies. So discussions have been ongoing, as well as alternative ways of achieving these COVID-19 technologies. This has been going on through voluntary measures. Unfortunately, very, very few intellectual property owners have shared their technologies, and all have turned down the opportunity to voluntarily share the same through the World Health Organization COVID-19 Technology Access Pool. So there is the possibility of production of these technologies from Africa. or the importation by governments from other providers. As you see, as you've heard from other speakers, Africa is importing, over 80% of what we need, for COVID. And so there has to be a change in this. As DNDI, we have observed the benefits of sharing research technology to enhance research capacity. The TRIPS waiver should enable unrestricted sharing of knowledge, the technical know-how, and data without any fear of infringing intellectual property rights. So it is not acceptable that the people in Africa are being held hostage due to the lack of access of COVID-19 technologies. And for this reason, we support the TRIPS waiver proposal. As has been said by the speakers before me, no one is safe until we are all safe. So as DNDI, we believe that health tools could be free of intellectual property restrictions, which prevent affordable and equitable equitable access and obstruct research and large-scale production. We think technology transfer should either not enforce the existing IPs. I mean, technology owners, should not enforce their existing IPs or share it via non-exclusive licensing globally, so that the COVID-19 technologies become really truly a global public good. We consider it important for countries to have the possibility to serve their populations by having alternative productions. And therefore, we support the TRIPS waiver. If production is scaled up, the people who have access are the most vulnerable, those at the highest risk. So if we don't really scale this up, these people, most of them within Africa, are the ones that really will bear the greatest burden. We would rather not be in this situation that we really found ourselves in as Africans, but the solutions lie in the hands of the IP owners, and should they fail, we strongly suggest that governments must take leadership. As you've seen, the leadership already taken by the government of South Africa and India, to bring this waiver to our notice. So African countries have shown this leadership by supporting the waiver proposal that was put, as we have heard from the African CDC through African Union, and quite a number of them have already endorsed the waiver. And South Africa, we really want to thank South Africa for co-leading the waiver proposal at the World Trade Organization. As a globally networked organization, we understand that people in Europe and the US have faced similar difficulties in the past, and in some countries in Europe, they've been looking into increasing their production capacity as well. This pandemic to us has been a wake-up call for Africa. Moving forward, we need to look at how we can increase the research and development and manufacturing capacity in Africa, as been said by previous speakers as well. So let us keep these discussions going even as we end this webinar through all the available digital platforms. Remember what Dr. Guel said, and I like to quote him that time is of essence, and let us work together and move fast to achieve our goal, which is ensure that the waiver is approved. No one is safe until we are all safe. So thank you very much, and over to you, Spring.
Thank you very much, Monique, for those rallying words at the end of this webinar. We'd like to thank all of you who've joined us. There were more than 200 of you from around the world. We know that there is a groundswell of opinion, that there is a need to act with speed, as Dr. Ogwell has said, with solidarity, as all the speakers have alluded to, and with the public interest at heart, in order to make sure that the toll of the pandemic is limited to and reduced day by day, rather than compounded if we do not take global collaborative action. We look forward to your playing a role in either leading, if you are in such a position, this global social contract, or pushing those who are in leadership positions to engage on this global social contract for all of humanity, so that we actually achieve the SDGs, but also just so that we protect the right to health. All of us have the right to health. Thank you very much. Have a good afternoon, evening, rest of your day. We look forward to the progress that is made on this and all actions in support of our common humanity. Thank you. Bye-bye.